The importance of anticoagulation management in primary care has changed over the last decade, I would say, mainly due to the increased numbers of patients taking it, mainly because of atrial fibrillation. So this has led to pressure on hospital clinics, which has translated into pressure on primary care, which means we've had to get more involved in managing patients receiving oral anticoagulation therapy. The introduction of the new oral agents will be a challenge for primary care. The main focus, I think, is that we get more patients with atrial fibrillation on oral anticoagulation, and in the meantime, through agencies such as Anticoagulation in Practice, we can work out the best treatment strategy for the individual patient. I think the impact of the new agents within primary care will be twofold. One is that I think primary care needs to gear itself up to manage atrial fibrillation much more than it has done traditionally. And secondly, for those of us who manage anticoagulation clinics in primary care, there will be a shift of emphasis from warfarin to the new agents.
I think the shortcomings of the vitamin K antagonists that we need to consider are the fact that they need their regular monitoring. And many people find that they are very life-affecting, affecting both their dietary intake and also other medications they may wish to take.
I think over the next 5 to 10 years, anticoagulation management will change quite significantly, not only because of the new oral anticoagulants, but because also of the change in the antithrombotic management of AF. At the moment, we're using antiplatelets such as aspirin for a large proportion of our patients. Current guidance suggests that antiplatelets are not effective, and so there's a whole shift away. We'll see the majority of atrial fibrillation patients on anticoagulants, and we'll see a larger proportion of patients on these new oral anticoagulants, and so we'll be better able to manage, hopefully, patients' adherence, and hopefully we'll start to see a reduction in stroke prevention because we've got better access for patients to anticoagulation therapy.
I'd have to say that the important message here is that aspirin is an ineffective treatment for patients at risk of stroke and atrial fibrillation, and we should be anticoagulating more of those people. With the advent of the new anticoagulants, we no longer have just warfarin as an option, but many here are more on the way.